the Sri Lanka College Specialist Family Physicians. So before we get started, I'd like to remind a few housekeeping points. Please ensure that your Zoom display name matches the name you would like on your participation certificate. And toward the end of the lecture, we'll share a link in the chat for a feedback form. Completing this form and attending the lecture for a minimum of 45 minutes are required to receive your certificate. The feedback form will include 3 multiple choice questions. Please select the correct answers using the check boxes. The correct answers and your participation certificate will be emailed to you. If you have any questions, please use the chat box and we'll address them at the end of the presentation. So to make sure there's a smooth session, please keep your microphones muted at all times. So tonight we have the privilege of hearing from Dr. Solith Senanayake, consultant cardiologist and lecturer in pharmacology at the Faculty of Medicine, University of Sri Jayewardenepura. He will be discussing on dyslipidemia in primary care, updated management strategies. So over to you.
Thank you very much for that kind introduction. I'm just trying to get the slides online. Just bear with me for a second. So I believe it is a topic that basically most of you in your primary care or something that you probably do come across very regularly in your day-to-day practice. So the management and the guidelines have changed a bit during the last couple of probably decades. The important thing is we see that there is a gap between what is known and what we practice. So let's see, after this lecture, I hope that I might be able to bridge the gap at least to a certain degree. So let me basically share my screen. So here we go. Let's see. I hope all of you can see the screen properly. So the topic for today is we're going to discuss if your cholesterol or the lipids is too high. So let's talk about what we already know about. So why do we have to worry about having high cholesterol or high lipids? There are different theories that some people even say that having high cholesterol is actually a good thing. So atherosclerotic cardiovascular disease is still the #1 global killer. The most common being coronary artery disease, but it's an umbrella term that we use even to talk about stroke. So it is still the #1 killer. Proven effect of high cholesterol in atherosclerotic cardiovascular disease. So it is proven that it plays a major role in the development of atherosclerotic cardiovascular disease. So the primary goal is to reduce cardiovascular disease and death. So that would be your ultimate target when we talk about preventative cardiovascular medicine. So a little bit about what happens in the vessel. as you know, so this is, I guess, basic physiology and biochemistry. All of you who are probably health professionals would have gone through this. So basically, just to recap what you already know, you know what we take as exogenous dietary fat uh, comes in as chylomicrons. So chylomicrons are uh, basically rich in triglycerides. So they become, with the help of lipoprotein lipase, they become chylomicron remittance, which is basically taken up by the receptors in the liver. And then the liver is the primary source, which basically from the dietary intake, and probably depending on your genes, acts as the primary, what you call a factory, which produces the cholesterol. So basically, VLDL is what is basically, so it's a group of lipoproteins. So VLDL is the initial particle which is basically produced, which is basically again broken down into IDL, and then further broken down into LDL particles. So LDL particles are small particles which basically can go through the endothelium and get deposited within the intima. So the extrahepatic tissues do have LDL receptors. So the HDL, the main function of HDL would be to basically bring back the cholesterol particles back to the liver. So that is why it is called the good cholesterol. So whatever it is deposited in your peripheral tissues are brought back through HDL back to the liver. So this is basically what I described. It's the pathway that we come across. So sources of cholesterol, the most common source would be the food that you take in. Some of the cholesterol comes from the adipose tissue, that is your fat, and then a certain percentage comes from the liver synthesis. So it is basically you need to know a bit about the sizes of these lipoproteins. So chylomicrons are basically the largest particles. They range from about 75 to 1,200 nanometers. So they don't. So why we say triglycerides don't directly contribute to atherosclerotic cardiovascular disease is that chylomicrons basically cannot move through the endothelium into the intima. So the smaller the particle gets, the higher chance that they will go in and then get deposited. So you would ask, HDL is probably the smallest. So HDL is basically too small. It will basically not retain within the intima. So it moves, so it can go in and go out. So the LDL, IDL, VLDL, those are the particles that can basically remain. But out of that, LDL is the one which is basically known to cause this atherosclerotic cardiovascular process. So types of lipoproteins in our circulation. So plasma proteins, like I said, are divided into chylomicrons, HDL, and atherogenic non-HDL cholesterol. So atherogenic non-HDL cholesterol will have VLDL, IDL, and HDL. So HDLC. So HDLC also has two components, the LDL that we most commonly talk about, and the lipoprotein little a. So that is another particle which now is coming up in the evidence to show that that also plays a big role in the development of atherosclerotic cardiovascular disease. So basically, VLDL, IDL, LDL all contain above 100. So that's the lipoprotein, which basically will basically act as the transport protein. So all these lipid particles, these lipoproteins basically act as a covering shield. So that, because lipids itself can't normally transport within the circulation without the support of a lipoprotein envelope. So the important is they act as carriers. Pathogenesis of atherosclerosis, basically, like I said, normally what happens is through the endothelium, they will go in to the intima, and then the lipid particles will be taken up by the macrophages, and then they become foam cells, and they ultimately form a lipid core. So that is, it's a very basic schematic diagram. What you need to know is that the like I said, the lower the particle size, the higher chances that it will get deposited in the within the vessel. So this is what basically happens. I guess this is what basically contributes to the atherosclerotic cardiovascular disease. So this is the ultimate result of this is probably like a fatty streak which has become an atherosclerotic plaque. So ultimately what happens is, normally by the age of probably 12 or let's say 15, 20, at your teens, you start developing these fatty streaks depending on your genetics, your lifestyle behaviors, and probably the level of cholesterol within your body, and the time duration, which is also like a factor. The duration of the elevated cholesterol will basically is directly proportionate to the development of these plaques. And ultimately what will happen is that there can be a probably a damage to the surface of these plaques, and that will basically lead to a cascade of events which will ultimately like cause a clot, which will cause a complete blockage of the vessel, leading to a heart attack. So that is what the basic pathology of what we talked about. So how do we calculate your LDL? So why we talk about LDL again and again is that it is the cholesterol that we basically are more interested in when it comes to prevention of disease. So the known formula is basically LDL-C is total cholesterol minus HDL minus triglyceride divided by 2.2. So you need to know the level of triglyceride and the HDL and the total cholesterol, then you can get idea about the LDL. But what happens is, with high triglyceride values, so more, if it's more than 400, you cannot use this formula. And if it's very high, then you probably have to, so think of a non-fasting, a fasting lipid profile, because now the evidence is that you can also try a non-fasting lipid profile. One second. So non-fasting lipids, traditionally, I think what we all know is that when you basically advise a patient, you say you have to fast for 12 hours. So that is what basically is what we normally tell most of these patients. But it doesn't have to be that always, because some of the recent systematic studies comparing fasting and non-fasting samples basically have shown there's no significant difference when it comes to LDL levels. So most of the time, the non-fasting sample will have a higher triglyceride level, usually about 25 to 27 milligrams per deciliter. So if you think that the patient's triglyceride is not very important, you can always, or somebody you want to do a lipid profile as a screening, you can always ask, because sometimes patients find it difficult in the primary setting to, maybe people who are working or who are actually having busy schedules, then sometimes you can even order a non-fasting lipid profile. There won't be a big difference. So this is something that we normally come across. If you go through most of the lipid profile reports currently, even in Sri Lanka, you will probably get something like this. Be it the government sector, be it the private sector, most of the time, this is something I think I'm pretty sure that most of you would have come across. Something similar to this. So, and a lot of patients will probably come and tell you also that, okay, doctor, my lipid levels are within the normal range. So, as primary care physicians, I think it would probably be your duty or responsibility to basically educate them or not give them a false assurance that their lipid levels are normal. So, I mean, most of you would probably agree that it might have happened to all of you, that people will come and say, okay, or they do a lipid profile by themselves and they think that that is normal. So most of these levels are quite outdated. We don't normally now talk about levels. What we basically talk about in our current practice is that we give the patient targets according to their risk level. So that is what you probably need to practice, that you need to calculate your or the patient's risk for the next 10 years. And then, so these are patients who've not had any previous cardiovascular events. So the key concepts of treating would be, do not follow or treat patients according to the given ranges, like what I said. So your primary target in treating your lipids would be your LDL cholesterol. Patients will come and say, my total cholesterol is okay, or my total cholesterol is this. What you need to educate them is that it's not your total cholesterol which matters, because it does contain HDL also. So if your HDL is high, your cholesterol total might go up. So VLDL and IDL both carries triglycerides, but they also have ApoB100. So this can lead to residual disease, but we don't talk about treating VLDL and IDL separately, but the targeted therapy that we basically give would basically cover some of these residual particles as well. So total cholesterol and HDL, not the primary treatment targets. Yes, HDL, we need to bring it up, but unless you bring down your LDL, there's no point of just trying to bring up HDL. I think this is a good diagram. Basically, it is from the ESC guidelines. The treatment target. So if you basically know this, you can basically treat most of your patients or educate them in most of the cases. So you categorize the patient's risk according to several categories. So one thing is that if the patients have not had any cardiovascular events, you have to use a risk score. So there are different risk scores for calculating your 10-year cardiovascular risk. The score which the Europeans use is widely popular in the European region, but unfortunately we don't have. So there is the WHO score. I guess probably you would be able to tell me what scores that if you're using any kind of, or if you're familiar with any of the risk scores. I would like to get your feedback as well, what you're basically comfortable with. So there is one score called Q3 risk score, which I use because that it comes in app. So there are numerous apps you can use. Q3 risk does have a component for the Asian population. So that's why I use it. But you can use any validated score to basically calculate your cardiovascular risk. So most patients, young people, would fall under the low risk. So that would be less than 1% of chance of getting a coronary event within the next 10 years. So most of the young population would fall under that category, and then you need to advise them your LDL target should be 160. It shouldn't be 150, it should be 160 or 130. So if you have moderate risk, that is the score between 1 to 5, or even young patients with type 1 diabetes who are less than 35 years, or type 2 diabetes who are less than 50 years, without other risk factors, if you're a diabetic under 50 years, you do fall into the category of moderate risk. So you have to advise them that your target should be 100. So most of the middle-aged people who do have diabetes and all, your target, they need to know that their target is 100. Or the other thing is, so the definition of high intensity statin, that is something that you need to know. What is this high intensity statin and moderate intensity statin? So the definition of high intensity statin is, so there are few indications to start high intensity statin. One is if your LDL level is more than 190, and if you're above 35 years. So the principle of giving high dose or high intensity statin is that a high intensity, so the high intensity statin would basically bring down your LDL by 50%. So let's say if your LDL is 240, or let's say 190, and or let's say 200, and you're at moderate risk, you're never going to bring down your LDL up to 100 by giving a moderate intensity statin. So let's say atorvastatin 10 or 20, unless there is a big dietary component. So yes, for all of these patients, your first advice would be lifestyle changes or assessment of their life, the lifestyle habits, their diet, exercise, other risks, like risk, basically have an idea about that, and basically advise them to make those changes. But I've seen practically, can you guys hear me?
Yes, sir.
Okay, sorry. I think the line got a little disconnected. So basically, like I was saying, lifestyle modifications would be first. But even for some people I've seen who are basically sticking to the diet as much as possible and even doing regular exercise, it's difficult for them to bring down the cholesterol. One thing is the food patterns that we basically use, the Sri Lankan food pattern. It's really difficult to basically religiously stick to a low fat diet. So I've seen that being one reason that even with people who are very careful with their diet and exercise, still have not achieved their targets. So as we go on, if your risk is very high, so I've given the risk factors, your target would be 70. And any patient who's had a MI or a stroke, or who's even had a stent without a MI, your LDL target, they fall into very high risk category. So remember, their target is 55. It is not 70. It is not 65. So I'll counter that when we do a question. And if you've had two events, let's say or your patient had a stroke in January, and in March or May you develop a heart like a MI, then eventually they fall into very high risk category. So your LDL target should be 40. So these are the targets. So I think this diagram or the chart would basically give you a bigger idea on, or a basic idea on, how you should basically advise your patients. So when you're managing your patients, the targets that you have to basically uh, get them onto. So who do we treat? Like I said, you need to, for patients who've not had any cardiovascular events, or young patients, you need to assess their risk. Like I said, if it's very high risk, your target is 55. If you're at a higher risk, it's 70. So if your blood pressure is uh, basically more than 180 or over 110, family history without other risk factors, moderate CKD, long-standing diabetes, total cholesterol more than 310, or LDL more than 109. So they fall under high risk. So it's most of the time, like I said, if you go through the chart, the lipid profile report, they would basically not give you these targets. So remember, your goal is achieving your targets, and it's basically a individualized treatment process for each of these patients. So you can use any risk score at least to get an idea of where the patient stands. So the score has a low risk chart and a high risk chart depending on the geographical location in Europe. So unfortunately, this is not validated for Sri Lanka, but there are other so I think some people have asked questions, but we'll answer the questions at the end. So use any chart. There's WHO chart. So score cardiovascular risk, 10-year risk calculator would basically consider your blood pressure, whether you're a smoker or not, your total cholesterol level, and your age, and whether you're female or male. So your gender also matters. So this is what we talked about earlier. If you're very high risk, it's 55. Low risk, it's 116. So the downside is that there are things which basically factors which modify the score, which is basically not incorporated into this calculation. So it could be social deprivation, especially obesity, physical inactivity, stress, family history of premature coronary artery disease, chronic inflammatory arthritis. So all of them actually do modify the risk score. So which is not basically incorporated. So in that case, it's your individual decision, or you have the liberty of basically making that decision of uh, considering to alter the target level. So it's basically, so there are other things which, like psychiatric disorders, HIV, left ventricular hypertrophy, CKD, which basically plays a additional part. So treatment options, like I said, the core would be lifestyle modifications plus statin. So in preventing atherosclerotic cardiovascular disease, your core treatment would always be statins. Then, if you haven't achieved your targets, there are other things like ezetimibe, PCSK9 inhibitors, And this is a very interesting drug, Bempedoic acid, which has come into the guidelines very recently. So if the guidelines now recommend the 2024 chronic coronary syndrome guidelines basically do talk about Bempedoic acid. Lifestyle modifications would be things that you already know. You need to stop smoking because you need to advise them to stop smoking. Smoking basically has several negative effects on the endothelium, which accelerates atherosclerosis. Healthy diet, physical activity, uh, monitoring the blood pressure and body weight. So intense, this is something you can have an idea about. So basically, intensity of lipid lowering treatment. So if it's a moderate intensity statin, it will only reduce by 30%, like I said earlier. So high intensity statin would be 50%. So if you, let's say, for example, you started a patient on high intensity statin who's at probably high risk. So your target should be 70 and you have not achieved it. Then you can basically add Ezetimibe, which will bring down by 65%. PCSK9 alone will bring this down by another 60%. So if you combine statins, PCSK9, it would be 85%. So there are risk groups who are on PCSK9 inhibitors, especially in Europe. I worked in a center which had a specialized lipid center, and they used PCSK9 inhibitors quite often for high-risk patients. So what you basically target is absolute reduction of LDL-C and your desired target. So a little bit about the drugs that we talked about. So HMG-CoA reductase inhibitors, the statins, they basically CoA reductase. So that is the rate limiting enzyme, which basically is responsible for converting HMG-CoA to mevalonate. So which is the precursor of cholesterol. So this basically inhibits the rate limiting step. So that basically reduces the synthesis of cholesterol in the liver, and it will also increase the number of LDL receptors on the hepatocytes. Thereby, what happens is that will basically increase the absorption of circulating LDL cholesterols because the receptors are upregulated in the liver. So statins have basically day in and day out basically have proven that they reduce all-cause death, stroke, myocardial infarction, and any coronary revascularization. So they've compared rosuvastatin and atorvastatin both, and both have shown significant reductions in these outcomes. So there are many trials which have proven that they significantly reduce all of these outcomes. So statin-related side effects, something that people worry sometimes too much. Yes, some of the patients can develop statin-related side effects, mainly myopathy, myalgia. Very rarely you can get hepatotoxicity, rhabdomyolysis, and induction of liver enzymes. But if you take the number of patients or the proportion, that is very minimum. So the benefit of taking a statin would basically outweigh any of these side effects. Most patients will come and say, because patients know, so they will come and talk to you about the new onset diabetes. So they read up and they come and say that there is a risk of diabetes, so should we take it? So what you need to basically tell them is you can do your basic screening for diabetes, like do HbA1c, fasting blood sugar. So you know that the baseline, the patient is not diabetic. And then basically safely start on this treatment, because like I said, the risk, basically the benefit outweighs the risk. Ezetimibe is another medication that we now, I think most people use, especially the physicians and the specialists. But I believe that is the same in the primary care setting as well. If you know that how it works, people. But uh, it's unfortunate to say that I've seen some of the patients being started on ezetimibe as the first line medication, which should not be the case. So uh, there's no evidence to say that ezetimibe alone has MACE outcomes. So cardiovascular outcomes always comes with a combination with statins, unless you're really, or the patient cannot basically tolerate ezetimibe. So what ezetimibe basically does is they inhibit the sterol transporter at the brush border, and they basically consequently reduce the intestinal absorption of cholesterol. So, so normally the dose is 10 milligrams. Common side effects would be like diarrhea. Uh, Sometimes they can get stuffy nose. They can have uh, kind of feeling like a viral upper airway tract infection, more like allergic rhinitis, or that feeling of uh, probably uh, something like uh, a runny nose or something, but it's very rare. And rarely they can get joint pains. But most of these side effects are very mild, and they normally tend to wear off within a couple of weeks. PCSK9 medication, which is given either 2 weekly or 4 weekly, and there are newer ones which you can give 6 monthly. And they have proven to reduce cholesterol by a significant amount, and they, in combination or alone, have reduced most of the cardiovascular complications. The problem is it is very costly, so it is not freely available, and it is normally used by specialists who basically manage uh, lipid disorders only, or physicians who are specialized in advanced lipid management. So I'm pretty sure this is something that you will hear more and more in the near future, because it is a hot topic. Bempedoic, we still don't have licensed medication in Sri Lanka, but uh, bempedoic acid, basically it's an inhibitor of adenosine triphosphate citrase lyase. So it basically blocks at a higher level in the HMG-CoA reductase pathway. So kind of similar to statins, but you can't use it in patients with hyperuricemia and anemia. But otherwise, it's a quite safe drug. I have had personal experience using this, uh, and the results are quite promising, because there's this clear study which basically came in not too long ago. This was used in patients who cannot tolerate statins. So they checked whether giving bempedoic, I mean, uh, apart from reducing the LDL level, does this actually have a benefit in preventing cardiovascular disease? And the results were quite promising. So this medication was well tolerated, reduced LDL cholesterol by 21%, and it reduces high sensitivity CRP by 22%. And they looked into 4 primary endpoints, that is uh, myocardial infarctions, coronary vascularization, all-cause mortality, and all that. So it promisingly reduced most of these the primary outcomes. So those are the medication. That's a little bit about the medication that you normally use. I want to highlight a little bit about the familial hypercholesteremia. So again, it's a topic that I think some of you would have come across. People would have come and said, my cholesterol is high because it's familial. Or you would probably tell, I'm pretty sure after asking the history, you would have said, this might be familial. So how would you actually know whether there is a familial monogenic component? So polygenic familial hypercholesteremia is not very uncommon. So that is, there are different genes which basically plays a role in increasing your level of cholesterol, but that is most of the time seen with your dietary habits as well. So it's not something that uh, that is not like you can basically control that. But what you should be interested is whether there is a monogenic or a true genetic, uh, basically a genetic reason for somebody having a very high cholesterol level, and whether it's homozygous, because then the children will manifest much earlier. So familial hypercholesteremia is a common genetic disease, and it's basically caused by the mutation of one or more genes critical for LDL cholesterol synthesis. So the clinical syndrome or the phenotype is characterized by extremely elevated levels of LDL-C. The problem is these patients have the propensity for early development of atherosclerotic cardiovascular disease. So what happens is somebody with familial hypercholesteremia might end up getting multiple heart attacks even before the age of 30, 20, sometimes even earlier. And the next generation might have high cholesterols even before that, because the homozygotes basically will develop at a much earlier time. So we'll answer the questions. So how would you suspect whether the patient is having? So we use these two criteria, what is called Simon-Broom or Dutch lipid clinic. I think the Simon-Broom criteria is much easier to remember. So if you get a patient with the very high cholesterol, see whether your total cholesterol is basically more than 290 and your LDL is more than 190. So if you have that, and see whether there is a history of myocardial infarction in your first degree relatives before the age of 60, or any second degree relative before the age of 50. So I'm telling you the practical aspect, how we do it, because, and look for xanthomas, uh, either the patient or the first degree relatives. So if you have criteria A and B or C, so if you have to have A plus B or C, then you know that is definitely a familial hypercholesteremia. So possible would be A and B or A and E. So these are the possible criteria is what we can basically do, or ask the patients, or do it as a screening, because the difficult part is to basically do a LDL receptor or a gene study. If you have that confirmation, you can without a doubt say the patient has a familial hypercholesteremia. So I think at primary care level, what you need to know is that go through the lipid profile, see, always ask about the family history. And another catch is that practically you will see that their HDL, they might not be very active, but their HDL might be very high as well. So that is, the gene produces high HDL also. So that might give you a clue that this might be a familial pattern of presentation. So always, so all of your patients, if you think that the practical important thing is, so if they are familiar, if they are proven familial hypercholesteremics, your LDL target should be much lower. And you need to advise the family that they need to screen their children at an early age. That's another thing you can do practically. If you think that somebody might be having a familial hypercholesteremia, maybe their kids, just do a lipid profile and see. You might catch somebody who's actually a younger patient who's having or a person having very high levels. So just be aware of this. Dutch lipid clinic criteria is a bit more complex. I basically use this, but this also can be used. So this is what we discussed. So if you think if the patient is familial hypercholesteremic, then your targets and your screening of the family is important. So case history: 52-year-old businessman, type 2 diabetes for 12 years, on treatment for hypertension, presented with chest pain and found to have an anterior STEMI. Patient underwent thrombolysis, discharged on optimal medical therapy, atostatin 40 milligrams. You bring down the patient at 6 weeks. Are you happy? I think I should have given this before we started the lecture, but everybody happy about this? This happens quite a lot because you get patients like this and they go home happily thinking their LDL level is okay. So so second case, so I'll finish the first case. So let's say somebody has, so somebody has said depends on the initial LDL level. But like I said, remember this patient has had a STEMI. So any patient who's had a cardiovascular event, your LDL target should be 55, irrespective whether they've had a stent or not. Your target should be 55. It doesn't matter. So either it should be less than 50% or at least 55. So let's say this patient starting LDL was 90. Then if this patient's LDL was 90 at the beginning, then your LDL should have been 45 because you need at least 50% reduction or at least 55. So 58-year-old female, receptionist, family history of ischemic heart disease, consumes alcohol and smokes, occasionally BMI 33, blood pressure 165/96, HbA1c 62, fasting blood sugar 117. LDL is 98. Total cholesterol 172, triglycerides 290. Happy? What would you basically start this patient on? You would probably, this is like probably a Sri Lankan scenario. So probably anybody wants to comment or?
Atorvastatin.
So you think the patient should be on atorvastatin?
Should start.
So we
What
don't know her LDL level, so we should know the LDL level before we target it.
with the history, what do you think what risk category do you think that the patient falls under? So
High,
always look like yeah, go on.
high risk, no?
You were
High
saying?
risk. High risk.
Yeah, so that's the very good. That's the important thing. Because a lot of people will just see this and treat the triglycerides. Like I said, now what we basically focus is on the risk stratification. So after you go through the history, if you think that this patient falls under high risk, your initial target would be to bring down your LDL to your desired target. So your statin would be your primary treatment option in this patient. That invariably would bring down your triglycerides to a certain degree. But unless if it's more than 400 and unless there is a risk of pancreatitis, triglycerides basically don't have a direct impact on atherosclerotic cardiovascular disease. But I think there is new evidence coming up slowly that triglycerides, sometimes the chylomicrons, do have remnants of the IDL and the chylomicron remnants might play a role in atherosclerosis, but the evidence is not very probably very strong. So from the evidence that we have up to now, treating the LDL targets would be your primary endpoint when you treat these patients. So I think you made a very good answer, because go through so these patients with diabetes without target organ damage, duration for more than 10 years. So just get familiarized with, or you just keep that chart. I think that would be, if when you're at your primary care setting, it's probably good to have this lipid chart where you can quickly go through and basically categorize their risk according to so that you know what target level that you're going to achieve. So when it comes to Sri Lankan context, what is good or bad about us? So the normal pattern in the Asian population is that we have a lower LDL than probably the European. So if you take this patient, your LDL is, so this second case scenario is more of like the typical Sri Lankan kind of pattern. Your LDL is not very high. So this could be 130 or something. That is what you normally see, 150. Your LDL is HDL is most of the time low. So if you go through most of your patients, you will see majority will have low HDL-C, and they will have elevated non-HDL, elevated ApoB particles, elevated lipoprotein A levels, which we don't normally check, and elevated levels of small dense LDL particles. So the ApoB particles in the Asian population are basically smaller. So the number of ApoB particles would be, if you take the same area, the number of ApoB particles would be higher. So they carry more cholesterol when you take overall. So that what they say is the ApoB particles, the higher number correlates with a negative cardiovascular. So negative in the sense it basically correlates negatively And because it's an area where there is still research going on, so we don't have any treatment for this, but these are particles which are being thought that plays a role, but we don't have direct markers to check the levels in our clinical practice. So that is the problem. But I think in the future, these will become more prominent when you talk about treatment of the separate components. So common myths, a lot of people think too much, the lowering of cholesterol is not good, that there can be hemorrhagic strokes, risk of cancer, dementia, but none of the trials have basically shown any conclusive evidence that can basically affect any of these conditions. So I think if your risk is higher, reducing the LDL level to the required levels would probably have a more benefit than not. So basically what we see is, do we really practice what is known? What do you think? Do you think that we practice what we really know, or have you practiced the same way, or do you have a different experience that you would like to share? I would like to basically know your thoughts about that, your practical or things that you have basically faced practically when you're treating patients. So in the real world, we see a gap between evidence and what we basically actually practice. That is related to some of the patient factors, physician factors, and common myths, because sometimes the physicians do practice what they know or what the evidence say, but depending on the patient or the patient's response or the compliance, the practice could change. So know your target goals, understand your risk of atherosclerotic cardiovascular disease, and do not discontinue early. That's another thing that, I mean, all of you would have faced, that you start patients on treatment for a shorter duration, and then the moment you stop, within few months, they will come back saying that their levels are back to what it was. So you don't know what. So one thing is, even if you stick to a proper diet, the level of cholesterol synthesis is highly variable in each individual. So some people do, although they are not genetically, they don't have a familial gene, the proportion or the number of or the rate of synthesis of cholesterol might be higher than somebody else. So, and you might not be following the exact diet that you should. So in that case, you might not be able to, even if you discontinue, things will go back to the same level. So my professor used to say, after 40 years, everybody should be on a statin. So, I mean, some people would probably not agree, but people who do have high cholesterol, I think long term, we don't see, we don't have data to say that there are long-term negative outcomes. So what you need to probably educate your patients is to basically be compliant with your medication. So be proactive, not reactive. There's no point of starting statins after a major cardiovascular event. So as primary physicians, what you need to know is catch the patients who do actually need treatment, and then basically try to convince that they do need treatment to reduce the cardiovascular risk. Thank you. I am happy to basically answer your questions.
So there are a few questions in the chat box. Shall I read
Yeah.
them out?
Yeah, sure.
The first one, within what time frame should we achieve the target LDL level?
So if you've had a cardiovascular event, achieving the targets as early as possible would be the ideal scenario. But there is no exact time frame, but what we see is, let's say your target LDL would be 70, and you've started the patient on high intensity statin. You have to at least give 6 weeks, 6 to 8 weeks for the medication to act and then achieve the target. So do not probably repeat a lipid profile or reassess within about 2 to 4 weeks. So I think that would be too early. So, and there's no point of taking too long. That is maybe like 6 months or 1 year. If you're taking that long, that means that you're basically not treating the patient adequately.
The second one, do Ezetimibe has cardiovascular mortality benefit compared to statins, and whether it is safe in during the breastfeeding?
So basically, the trials show that statins are basically, there's no head-to-head trials with atorvastatin and ezetimibe, but what they've seen is the combination basically has benefits. So when you compare with atorvastatin and ezetimibe, your primary treatment option should be statins to prevent the cardiovascular risk. Ezetimibe would always be add-on therapy unless the patient cannot basically tolerate. But the benefits of statin you wouldn't see with ezetimibe. The benefit comes from achieving your target and reducing your cholesterol levels.
If we are to suspect familial hypercholesterolemia, are we supposed to do genetic studies, and can it be done in Sri Lanka?
So ideally, yes, the whole point of considering the criteria and basically, so like I said, the criteria gives you an idea whether it's confirmed familial hypercholesteremia or possible hypercholesteremia. So in that case, if it's basically probable, the ideal thing would be to do genetic studies. But we don't have the facilities to do it here. But there are few studies which are going on. So Kalugovila Profinit has a cohort of familial hypercholesteremia patients. Or even if you refer somebody to us, what we can do is we try and send the genetic studies to India. It is very costly, but for some of the patients that can be done, even if it takes time.
The next one, what is the lowest age limit to start statin in children?
So in the practical aspect, I've seen patients who are even younger than 10 years who are on statins, but not in Sri Lanka. So the whole family are positive for the gene, and then at very young age, even before 10 years, they have very high cholesterol levels, so that the chances of them getting a cardiovascular event is very high. So those patients I have seen that they start very early, but all of them are genetically proven familial hypercholesteremia patients.
The next one, what is the maximum dose of atorvastatin to use in high-risk patients? And is there a place in atorvastatin 5 mg nocte or 10 milligram every other day dose?
So the maximum atorvastatin dose would be 80 milligrams. So rosuvastatin would be 40. That is probably the maximum dose that you go on to. But what we see in practical setting in Sri Lanka, that is for the Europeans. Most of the Sri Lankans are on 40. Rarely you see somebody being on 80. The thing is, after 40 and 80, the margin of benefit is not very much. So, but your side effect could probably go up more with 80. But generally, people who tolerate high intensity statins, even at 80, they do tolerate. So don't be afraid to even give a trial and see whether it works. You can always, because you can always probably stop or discontinue or come down on the dose if you think that the patient is developing side effects. But the important thing is that you educate the patients on the possible side effects. Otherwise, they will probably stop the medication. On the other hand, when you tell about the side effects, even a small cramp or whatever, they will attribute that to your statins. So that's also another problem.
Sir, how to treat isolated hypertriglyceridemia, and is there a place in using omega-3 fatty acids and fibrates in that patients?
Yeah, definitely. I mean, isolated hypertriglyceridemia. So what they basically talk about is what we have, the omega-3, the fatty acid is not the ideal dose that they recommend. Even if you go through BNF or you read the literature, you don't have that high dose omega-3 fatty acid in Sri Lanka. But I've seen that even that does reduce the triglycerides to a certain level. But what we use is not the ideal one. It is not available in Sri Lanka, the PUFA one. But practically, I've seen, even I have used that you can use omega-3 fatty acid and you can use fibrates as well. If you think that it's not, there is a high risk of pancreatitis or something like that, you can basically, the main thing is you need to check the patient's diet. So if they're taking a lot of beer, probably fruity drinks, alcohol, if they are obese, all that would contribute to the high triglyceride levels. So before you start treating, you need to dig in a bit deeper into their dietary patterns and basically address that as well.
So there's a question regarding a patient who is a diabetic and has been on atorvastatin for more than 10 years and came with a CPK of 232, which was ordered due to non-specific joint pains, and it was thought as for a statin-induced myopathy, and all the other investigations were normal. And he's asking
I guess
whether to.
one important thing is that you should always check your thyroid levels when a patient comes with high CPK, because most of the time 200 is not a very high amount. You see patients with statin-induced myositis and myopathy, they normally have very high levels of CPK, but so it could be multifactorial. There are a lot of patients. I mean, if you go, you can probably do a study and see a lot of patients who are on statin would have a slightly elevated level of CPK. So if it's less than 4 times the upper limit of normal, you are not usually worried. It could be, like I said, it could be related to statins, but that itself doesn't basically explain why. If it depends on the degree of the patient's symptoms, I guess. So if the patient had like significant symptoms, you need to basically think about other causes as well.
Sir, they're asking the indications for fibroscan in hypercholesterolemia.
So fibroscan in hypercholesterolemia, but that is basically to check fatty liver, isn't it?
Yeah. They
I'm
are
not.
also.
So it's I am not 100% aware of that. I can basically look up on that and let you know. It's something I've not basically practiced. But as far as I know, you do the fibroscan to check the degree of fatty infiltration of the liver, isn't it?
Yes, so if it's like if we can calculate the FIB4 and if it's more than 2.67, then we can do a fibroscan.
Sorry, I didn't hear you properly.
Like if we calculate the FIB4 and it's more than 2.67, then we can go for a fibroscan. Other than that, like for moderate levels, we usually don't go for fibroscan, as far as I know.
So it's not related to your
This
level of lipids,
cholesterol.
isn't it?
Yes, yes, sir.
So that's why I'm not very, that's why I can look upon that whether there is any correlation of the level of lipids and a fibroscan, but I'm not aware of something like that.
Sir, they are asking, is there a cutoff level for triglycerides to start fibrates?
So what they say is you can, first thing again, lifestyle modifications. A second one would be you can use omega-3 as a first line. So the normal level would be less than 150. So if it's more than usually thousands, it's severe. So if it's more than 500, probably even without after your modifications and omega-3, you can basically think of starting fibrates to basically reduce the risk of pancreatitis. Nothing more than that.
Sir, they are asking about use of every other day statins and.
So that's again, there are some trials going on, isn't it? Even in Sri Lanka, I know there are several small studies which have looked into using atorvastatin 5 milligrams or every other day 10 milligrams. So the important point is you can use whatever the method, but the important thing is that you achieve the targets within a certain time frame. So, and when you achieve the target, how you're going to maintain that. So let's say you, a patient who has moderate risk, you brought down the LDL below 100. Maybe you started on a higher dose and you made some lifestyle changes and the patient is somewhat within the normal range. You can, and you think that the patient's compliance isn't that great, you can advise whatever the way, like it doesn't matter whether it's 5 milligrams daily or 10 milligrams every other day, as long as you stay at least within the normal ranges or the targets for a longer period of time. So I think that's why the targets are important, so that you know where you want to stand.
So the last question for tonight, how frequently should we repeat lipid profile once a patient started on lipid lowering treatment for primary prevention and secondary prevention?
So what the guidelines say is that until you achieve your target range or target level, at least you have to do 3 to 6 months. But if you have achieved the target and the patient is consistent with the level, you can do it every 6 months or even 1 year. So I think even in UK, if the patient is within the target range, you do it every 6 months, not earlier than that. There's no point. I mean, unless the patient makes a drastic change or patient says that I've defaulted or something like that. But for patients who are on secondary prevention, I think you need to be a bit more strict on checking their levels because they are at a higher level or higher risk of developing further events in the future.
So, shall we wrap up for tonight?
Yeah, sure.
Okay.
I'm sorry for the delay. I had to attend this case, emergency case. So apologies for that and for being a bit late on that.
Thank you very much, sir, for that informative presentation. And thank you very much for sharing your expertise with us today. And also, thank you very much for joining with us today. We hope to meet you all in another CPD event like this. We'll wrap up now. Good night, everyone.
Good night. Thank you.
Thank you.